Welcome everyone to this Public Health Voices seminar. I'm just going to give it another minute or so because we've got quite a lot of people signed up and I want to make sure everyone's in the room before we start. Okay, so welcome again to those of you who've just joined to this Public Health Voices seminar. My name is Jenny Woodman. I'm a Professor of Child and Family Policy at UCL in the Social Research Institute, and one of my roles is as co-director of the Children and Families Policy Research Unit, which is funded by the NIHR. I'm chairing this seminar today, so I'll be doing introductions and then chairing the question and answer session at the end and collecting your questions for our speaker. This seminar series is UCL run, it's Public Health Voices webinar series. It's run by the Faculty of Population Health Sciences at UCL. It's open to all, and we've got lots of people signed up today, so that's great. The seminar series aims to engage with and showcase how important it is to work in an interdisciplinary way within public health research and training. So this is the first Public Health Voices event of 2025, and we'll be looking at, our speaker will be looking at how we can use linked data to improve child health outcomes. So I'm really pleased to welcome Professor Katie Harron, who is Professor of Statistics and Health Data Science at the UCL Great Ormond Street Institute of Child Health. So Katie's work, which I'm quite familiar with, focuses on using data that are routinely collected from public services, so administrative data, to generate evidence on factors influencing child health and wellbeing. One of the things Katie does is leads the ECHILD Research Database, which links administrative data from health, education and children's social care from birth to young adulthood for 20 million people in England. And I'm sure we'll hear more about that in a minute. Thank you, Katie, for joining us. Before I hand over to Katie, I just want to draw your attention to the Slido link, which should be in the chat. You can use the Slido link to ask questions and then upvote questions. The most popular questions I will pose to Katie at the end, where we'll have 15 to 20 minutes for Q&A. Thank you, and over to you, Katie.
Thanks, Jenny. Very happy to be here talking about ECHILD today. So, as Jenny said, I'm going to be talking about how we can use linked data to understand the key maternal and early life factors that influence and improve child health outcomes. I want to talk about how we can use linked data to build a detailed picture of how children interact with different services as they grow up, and also what the opportunities and challenges are for evaluating early interventions. I'm going to be using a lot of examples of research from our team at the Institute of Child Health and aim to show how we can use these data to help government and service providers understand children's needs and identify those who might fall through the cracks. So first of all, why do we need to transform child health in the UK? This time last year, the Academy of Medical Sciences published a report on child health in the UK, and it highlighted a really appalling decline in child health over recent years. And the statistics really were quite shocking. 1 in 5 children by the end of primary school in the UK are obese or overweight. 1 in 4 had tooth decay. There'd been a huge surge in demand for childhood mental health services and in waiting lists. Infant mortality is now ranked 30 out of 49 OECD countries, and the number of children living in extreme poverty has tripled since 2019. One of the most important things that we can do to build a better future and to promote the nation's health and wellbeing is to start with the early years, because this is the time when the building blocks for lifelong mental and physical health are laid down. So to achieve this goal, we really need high quality health data, of course, to understand the needs of our children, but we also need to think beyond traditional disciplinary boundaries to understand the wider social determinants of health. and the relationship between health and other areas of our lives, including households that we live in, the schools that we go to, and the wider environments in which we live. For starters, we know that health and education are inextricably linked for young people. Children will struggle to get the most out of school if they have ill health, and poor mental health can be a barrier to learning. This study, which was led by Ruth Blackburn, shows the rate of stress-related presentations in hospital admissions according to school terms. So here you can see across all ages in secondary school, there's a clear pattern whereby admissions peak during term time and then dip here. You can see at Christmas, at Easter and during the summer. These are admissions that are predominantly for mental health conditions and include self-harm and pain. And they're really common. They affect around 2 girls and 1 boy in every classroom. But if we can use early indicators like this, then we have an opportunity to tackle these early signs of mental health conditions through effective and appropriate interventions, ultimately improving our chances of decreasing the likelihood of clinical conditions that might be more serious developing later in life. So educational experiences will obviously affect our health, but of course the opposite is true. In this study, we looked at the association between gestational age at birth and school attainment at ages 7 and 11 at Key Stage 1 and Key Stage 2. So we used linked data on the whole population in England, and we were able to identify the effect that each additional week of gestation had on outcomes, showing that being born even a couple of weeks early is associated with a lasting impact on children's ability to learn all the way until the end of primary school. But if we can share information across services, then we can provide clinicians, parents and educational professionals with more detailed information about the likely outcomes of children born at specific weeks of gestation and with specific health conditions, rather than grouping together all preterm pregnancies, for example, as smaller studies have done in the past. And this information then can be used to inform how clinical follow-up is implemented for preterm babies and to ensure that early support is there to enable children who are born preterm to have the best start at school. So in order to generate this kind of evidence that can inform policy, we need to bring together information not just on health, but on other aspects of children's lives. Administrative data, which is routinely collected data from services such as the NHS, education services, social care services, allows us to track individuals over time, meaning that we can see what happens in different parts of children's life. So, for example, in healthcare, we can look at birth records, we can look at A&E visits, we can look at anything that happens in hospitals. We could also look at education data and even children's social care data. But it's by cross-sectoral linkage that we can build this more detailed picture of how children interact with different services over time and how these different domains may interact with each other or affect outcomes across the life course. I think this is important because children and families don't view their lives in this sort of disparate way. It's all part of the same thing for them. And in fact, there's often a lot of frustration that children and families need to repeat their stories to all of these different services. So by linking these different parts of children's lives together, we get a much more holistic sense of their needs and a better understanding of how services might be able to provide support in a more joined up and cohesive way. So this is where ECHILD is aiming to fill a gap. So ECHILD is a national data resource linking information from health, education and children's social care, bringing data together from the Department for Education and NHS England. It's a data resource that really aims to straddle the health and non-health divide, working at the intersection of disciplines and aiming to avoid the disadvantages of working in data silos. We've got data on children born since 1984, so around 20 million pupils in England that we can follow up from birth all the way up to age 38 for the oldest members of the cohort. The data are linked by NHS England, de-identified, and then we access it on the ONS Secure Research Service. More recently, we've added in additional data sets, maternity services, birth notifications and registrations, mental health services data, and community services data, which includes health visiting. So I want to give some examples about how we're using these data to inform policy. And one of the things I wanted to start with is how we're using data to understand developmental and educational outcomes in children with complex, chronic or rare health conditions. And the reason why this is important is because over recent decades, there's been huge developments in healthcare and massive progress in survival rates for children with particular conditions. For example, those born at the limits of viability, really early preterm babies, or those with childhood cancer. So this means we've got rising numbers of children with these quite serious health conditions, in many cases surviving through to adulthood. Alongside this, we see changing recognition and recording of conditions over time. So, for example, increased incidence of autism spectrum disorder and mental health conditions in children. And an increased need to understand long-term outcomes in order to be able to drive improvements in not just survival now, but the quality of life of these children. We also need to understand children in their context, so not just as individuals, but in the context of their peers, of the schools they go to and their neighbourhoods, etc. Because most conditions will have different trajectories depending on those social environments. Existing research for these children has often been limited by small sample sizes, studies using clinical cohorts, for example, or short-term follow-up and loss to attrition as children transition from childhood to adult services, which has meant that historically we've had little data on how educational services, for example, can address the additional needs of these children. One of the studies that we're doing with ECHILD is looking at the impact of chronic liver disease in childhood on school readiness, which is measured at age 5. So chronic liver disease is a condition that affects around 400 children per year in the UK. And having liver disease means that livers can't filter the blood effectively. And so toxins that are normally cleared by the liver continue to circulate and can irritate the brain. We know that the brains of newborns and infants are very vulnerable at this time, and suspect that the liver disease at this period in a child's life might have a significant effect on neurodevelopment. So using a cohort of 5 million children in ECHILD born between 2002-2012, we identified children with chronic liver disease based on ICD-10 diagnosis codes. And these children made up around 0.2% of the population, so quite a rare condition. When we looked at the early years foundation stage profile, which is a measure of school readiness captured in administrative education data at school entry, we saw that children with chronic liver disease scored lower in all domains. So if there were no differences between groups, you would see effect sizes at the 0 line here. But we see that these scores are lower for children with chronic liver disease across all of these different domains. And the risk of achieving a good level of development, which is this binary indicator measured at age 5, was 20% lower for children with chronic liver disease. So less than half of children with chronic liver disease achieved a good level of development, compared with almost 2/3 in children without this condition. Because we've got such a lot of data, we have a greater ability to be able to explore different subgroups and to explore whether associations we find between diseases and outcomes differ according to different demographic factors. And in this cohort, we saw stronger effects actually in females, and also a pattern according to deprivation. So those in more deprived areas are more likely to be affected. This is quite interesting because females are more likely than males to have chronic liver disease, but actually chronic liver disease is less prevalent in the more deprived areas. So a lot more work to be done, but it's starting to help us think about the mechanisms by which physiological effects of chronic liver disease or its treatment might affect cognitive development and skills in childhood. So future work is going to look at later trajectories of educational attainment and try to understand whether we can work out optimal timing for intervention. So, for example, whether transplantation can reverse any damage that might have been done to the brain from liver disease. Through the NIHR-funded HOPE study, we're looking at a much broader range of health conditions and trying to understand educational outcomes across school age. And specifically, one particular group, though, is children born with neurodisability. So this work has been led by Anya Zilverstein with Ayana Kant and Laura Jimeno. And this plot here shows the proportion of children with and without neurodisability recorded in hospital records prior to starting school, who achieve, again, that good level of development at school entry. And as you might expect, those with neurodisability are less likely to achieve a good level of development, and these patterns continue through Key Stages 1 and Key Stages 2. These results here are for English, and we see similar patterns with maths. So although the difference between groups is relatively constant across primary school, what we do see is a big increase in the proportion of children with neurodisability who aren't included in assessments. So 1.5% in reception to almost a third in year 6. And it's really important to be able to take these groups into account to be able to understand overall patterns. Children with neurodisability make up about 3.5% of the population. So again, it's quite a small subgroup. But because we've got the whole population in ECHILD, we've got such large numbers, for the first time, we're able to drill down in a lot more detail and look at the characteristics and outcomes of subgroups using the whole population data. We're also using the data to look at school absences and hospital admissions for children with these conditions. One of the ways in which children with neurodisability are supported in schools is through special educational needs provision, which covers extra adjustments or adaptations to meet the needs of children who have health, learning or behavioural problems. 1 in 6 children have recorded SEN at any point in time, but actually 1 in 3 children have a recorded SEN provision at least once during their time in education. SEN is therefore quite a widespread intervention, but it varies across the country between schools and by pupil characteristics, and is widely regarded as being inequitable. And children with SEN tend to have worse health and education outcomes, but there's a lack of evidence on whether SEN provision itself as an intervention can improve these outcomes. And these are 2 research areas that the HOPE study has been addressing. In one piece of work led by Kate Lewis and Vincent Nguyen, we looked at variation in recorded SEN for children born preterm. And as we've seen, children born preterm are in need, many of them are in need of additional support. So this makes it a sensible indicator of underlying need. But the proportion of preterm children with SEN across the country varies from 12.5% to 29.4% by year 1 at school age. And this variation has led to a perspective that provision is a postcode lottery, that it matters where you live in terms of how likely you are to get that support. But by taking into account all the information that we have in ECHILD and adjusting for the detailed child characteristics that we have on chronic health conditions and birth characteristics, birth month, so what age you are in the school year, neighbourhood deprivation, free school meals, ethno-racial groups, and type of school, for example, we can see that actually very little of the variation that we observe is explained at the local authority level. So this seems to be showing that the variation that we do see is reflective of differences across the country and underlying need. Being able to look at smaller, more homogeneous groups of children can really help us dig into detail into the drivers of variation in school experiences. This study, led by Julia Shumway, looks at how children move in and out of different types of school support by exploring patterns of enrolment in mainstream and special schools for children with Down syndrome. And Julia has shown that in year 1, 2/3 of children with Down syndrome are educated in mainstream schools, but by year 6, this is reduced to just under 50%, meaning that around 1/4 of those who start out in mainstream schools have moved to special schools by the end of primary school. And we see that boys and those born to younger mothers or living in deprived areas are more likely to move. So this poses a question of why. Why do we see these patterns? In England, children with special needs have a legal right to be educated in a mainstream school alongside their same age peers, so long as the school can provide for their needs, and so long as in doing so, other students aren't negatively affected. Julia's done quite a lot of qualitative work, which has shown that parents want their children to be a part of the community in which they live, and they want their children to attend a school that has the right resources to meet their children's health and cognitive needs. So this qualitative work has been really important in understanding or helping us explain some of the patterns that we see. So I've talked a bit about support within schools for children with complex health conditions in the form of SEN. But within ECHILD, we also can look at support through children's social care services. So social care services aim to wrap support around children and young people and their families to provide safety, stability, and promote welfare. And like SEN, children's social care services provide support to a really large number of children. Recent work by Matt J highlights that although at any one time around 3.4% of children are defined as in need by the DfE, actually, if we look longitudinally at the data, 1 in 4 children are recognised as being a child in need at least once before they turn 18. So again, a really widespread intervention. But despite the support that can be provided, such as through out-of-home care, this group do tend to have poorer long-term health, education and employment outcomes than peers who are never care experienced. But up until now, little research has been able to quantify the overlap and the longer term outcomes for these different groups, those supported through schools via SEN or those supported through children's social care. So within ECHILD, because we have data from across these different services, we can really start to look at how this support overlaps. So this study led by Ruth Blackburn looked at the overlap between SEN support in school and social care support for children looked after, so children in the care of a local authority, and looking at a cohort of almost 3 million children in secondary school between 2007 and 2012, we showed that overall just over a third of children have some type of support. And although children looked after account for a minority, less than 2% of the school population, more than 3/4 of this group have SEN or education and healthcare plans. So children looked after are overrepresented amongst the children who are supported through SEN. We know these children are being supported through education and social care services, but we can also look at how they interact with healthcare services. So this plot shows unplanned admissions for mental health conditions in boys, which are highest for the children looked after groups and increase through adolescence into young adulthood. We see quite a different pattern actually for girls, with a sharp peak at age 11 to 15 years. This really highlights that although children like this are receiving statutory support from social care services and from schools, there's still unmet need in terms of effective mental health support, particularly for care experienced children and particularly for girls. Extending this work, research led by Anya Silverstein and Isabel Ward looked at mortality in the group of pupils supported through children's social care and SEN by year 9 or age 14. In this cohort, this group accounts for about 1 in 15 pupils, and this group had between 5 and 7 times higher risk of death compared to peers. There was an increased risk of injury-related death, particularly for boys and girls receiving social care support. And these are deaths that are potentially preventable in injury-related deaths through better support. And again, these are children who are known to services. They're being supported already, but they do seem to be falling through gaps in health and social care support. So this leads to questions about what needs to change. Is it better coordination of health, education and social care services? Is it better access to mental health services? Is it better support around transition out of children's services into adult services, in particular for CAMS and children's social care. Some work that we're doing looking at early indicators of this additional support is being led by Eleazar Luna as part of the ADR UK Community Catalyst for children at risk of poor outcomes. And here we looked at the number of A&E attendances in the 2 years prior to referral to children's social care. And you can see that the number of visits to A&E slowly increases in the 2 years prior to referral, and then there's a noticeable spike around the time of referral. So these services are sort of colliding. And after that, healthcare use remains stable but high. And you can see this more clearly when we look at the 30 days before and after referral. So what we're trying to do here is understand whether we can use information collected across services to have a more joined up approach, and whether we can identify patterns of healthcare use that could be used as early indicators for intervention. What I've presented so far is focused mainly on the individual, but just as health and education don't exist in isolation, neither do individuals. They're influenced by their mothers, their families, their households, communities. One of the really great things about ECHILD is that we can link maternal and child records. This allows us to use the data to understand, for example, which maternal factors during or before pregnancy are associated with outcomes, understand the intergenerational transmission of risk, which is becoming more and more important in the context of widening health inequalities. We can look at how different physical and mental health conditions cluster within families. Importantly, from a lay perspective, our public engagement work has highlighted that parents and carers are concerned about what happens, not just what happens to the child who has a complex health condition, but what happens to their siblings, sort of knock-on effects. And our ability to use siblings will also, to see siblings within the data will also enable us to do sibling study designs where we can try to start disentangling the effect of genetic and environmental exposures. But we don't have to stop with sort of maternal characteristics at birth. We can look further back at maternal trajectories of healthcare to understand what happens prior to or during pregnancy and how this might influence outcomes. So in this study, we looked at pre-pregnancy psychosocial risk factors in about 2 million mothers in England. And this plot shows the relationship between maternal age and birth weight in the child, according to whether or not the mother had a history of mental health conditions or hospital admissions for adversity-related diagnoses. So that includes violence, self-harm, and substance misuse. These groups account for a small portion of mothers overall, about 4%, but you can see that they're at higher risk of having a baby with low birth weight. The second plot here shows the relationship with infant admissions for injury, which shows the inverse pattern. So injury admissions are highest for the younger mothers. But older mothers with these other risk factors, who we can routinely identify in hospital data, also have poor birth and infant outcomes, as did the mothers living in the most deprived quintile, which actually accounts for the largest portion of mothers. So these data are showing us that we can routinely identify early risk factors in mothers prior to pregnancy using routinely collected hospital data that could provide us with opportunities to intervene and reduce adverse effects for children and downstream burden on health services. Up until recently, we could only link to maternal health records, but now through ECHILD, we can link back to maternal education and social care records. So some work led by Steffi Shi in our group is looking at child outcomes for mothers with a history of social care involvement. In this study, we looked at a cohort of around 200,000 babies born between 2012 and 2020, approximately a quarter of whom had been involved with social care services as an adolescent, or their mothers had been involved with social care services as an adolescent between the ages of 11 and 16. After accounting for a range of maternal characteristics, including maternal education, age at first birth, we saw that babies born to mothers with an experience of social care as an adolescent were more likely to be low birth weight and more likely to die in infancy than those with no social care involvement. They were also slightly more likely to have unplanned hospital admissions up to age 1, although these differences didn't seem to persist up to age 5. And then because we've got the education data now, we can look at that too. And we can see, again, looking at school readiness at age 5, very little difference here between groups, although the cohort is smaller because we could only look at children old enough to have school outcome data. So further work is going to extend these analyses to explore in more detail the type of social care involvement, for example, whether there are differences according to type and timing and duration of support. Other ongoing research using the mother-baby link in ECHILD is looking at migrant mothers and the outcomes for their children, and also other preconception risk factors and variation in child health and educational outcomes. So we talked about birth outcomes and looking longitudinally back in time at what happens to a mother. But another use of these linked data is that we can follow what happens to the mother going forwards in time. So in this study, we used linked mother and baby data to evaluate maternal mortality for mothers who gave birth to babies with neonatal abstinence syndrome, or NAS. And we looked at maternal survival at 5 and 10 years post-birth and found really large differences actually between mothers who did and didn't give birth to a baby with NAS. Other work has been done linking family court data with maternal health records, led by Ruth Gilbert and Georgina Ireland, and this demonstrates a similar difference in 10-year mortality rates between mothers who were enrolled in family courts and mothers who weren't, with more deaths due to injury and suicide. So taken together, these studies are really highlighting the need for mothers who've experienced difficult circumstances at birth to receive services to support their own health, as well as the health and well-being of their children. A further development that we've been working towards is to link to the unique property reference number, the UPRN, which would allow us to understand more about household composition and, to some extent, learn a little bit more about father figures, which is a missing piece of the puzzle still. This would provide much better data on how changes in household composition over time might affect outcomes, how clustering of health conditions might occur within a household. And then this could get much more insight into how, if we can intervene at the household level rather than the individual level, what sort of impact can we have? For example, if we treat parental mental illness, can we improve children's educational experiences? Or could providing appropriate support for children who need additional services then prevent escalation of mental health issues in parents? Pia Hardelid is developing another linked cohort which will exploit the potential of the UPRN for linking to environmental exposures. And this is the kids' environment and health cohort. It's going to explore how environmental exposures in childhood will affect health and learning outcomes across the life course. And this will really help us address some of the major public health challenges that we've seen in recent years, including the increased awareness of poor housing quality and overcrowding. Understanding the influence of these factors is really going to be crucial in planning interventions and improving outcomes. Okay, let's take a breath for a second. I've spent quite a bit of time describing how we can use linked data to better understand the picture of child health in the UK, moving away from silos, not just thinking within the boundaries of health, moving away from the individual and thinking about the child in the context of their mother and family and household characteristics. This descriptive work uses highly complex data, but it's often quite simple in terms of what we're showing, which groups are at greater risk for poor outcomes and who might stand to benefit the most from targeted support. But despite being simple, this descriptive work is really key because we can only improve services if we know how they're working on the ground. But this leads to the next question: what can we do about these differences? How can we transform child health in the UK and meet the current government's manifesto commitment to raising the healthiest generation of children ever? The Academy of Medical Sciences report, which I mentioned at the start, recommended that we need to implement effective early years interventions and address the decline in child and family health workforce. So in the next few slides, I want to demonstrate how we've been trying to think about using linked data to evaluate these early interventions. And this is really key because it's been estimated that the cost to society of addressing issues later on that might have been avoided through early action is 5 times the annual spend in England on early education and childcare entitlements. So to start with the Family Nurse Partnership, which is an intensive home visiting intervention for first-time mothers in England. There's a lot of evidence supporting its effectiveness in the US, but mixed evidence in the UK. But there's a lot of strong support for it locally, and it's one of the only recommended interventions in the Healthy Child programme for the under 5s in England. But only around 1 in 4 eligible mothers are offered a place on the FNP due to insufficient places on the programme. The figure on the right shows how this varies across the country, and in areas with higher numbers of teenage mothers actually we see lower enrolment rates. But we do know that those who are enrolled do engage well with the programme. This figure shows the proportion of mothers enrolled who receive the target number of visits at each stage of the programme. We can see from the data that the FNP seems to be targeted quite effectively at those who need it most. So these tables show the characteristics of mothers enrolled and not enrolled in the FNP based on a cohort of around 130 mothers compared between 2010 and 2019. Those who are enrolled tend to be younger, slightly more deprived, have more hospital admissions for mental health or adversity-related diagnoses. They're also more likely to have special educational needs or contact with social care services as a child. But these differences pose a challenge for analysis because we expect that mothers enrolled in the FNP will have different outcomes to those who aren't enrolled, independently of the intervention itself, because this is a more vulnerable group. So the question, therefore, is whether we can control for these confounders, things that are associated both with being enrolled in the programme and the outcomes of interest. In this particular study, we used propensity score matching to create balanced groups for analysis. What we found in the data was quite mixed. After controlling for all the differences we saw in the data, we saw little difference between groups except for a small increase in hospital admissions and maltreatment in the FNP arm. And we also saw a small improvement in school readiness, measured again by that good level of development at age 5. Now, I have to be quite cautious about interpreting the results from this analysis because it's very likely that unmeasured confounding remained, meaning that we couldn't capture all of the reasons why a particular mother would be enrolled in the programme over other mothers. For example, we don't have information on family support within the home, whether grandparents are there to provide support, for example. We can't capture granular details on household income, and we don't know whether a mother was experiencing domestic abuse. A more broad intervention is health visiting, which is a key early years intervention, universal in reach and targeted to those who need it most. Health visitors are trained nurses who are really uniquely placed to influence and work with the whole family in the interests of children on social, psychological and health choices. During the first 5 years of life, families should receive 5 mandated visits to promote their health and development and enable early intervention to improve long-term outcomes. And health visiting services are also designed to be responsive to children and families, and a lot of the support that's provided comes in the form of additional contacts outside of these mandated ones. But years of austerity cuts and a depleted workforce has meant that since 2015, the health visiting workforce has decreased quite dramatically by 37%. Work by Louise McGraw-Lone has shown that the real term value of the public health grant from which health visiting is commissioned has fallen by 15% overall, but has fallen by 37% for 0 to 5-year-olds, meaning that these cuts have disproportionately affected the youngest in the population. And in the context of this disinvestment, there's huge variation in how local areas are delivering their services. This research led by Win Liu has shown that the number of children receiving their mandated 2 to 2.5 year review ranges between 33 and 97%, depending on which area they live. Despite this pressure on services and the variation in delivery, we've been able to show that almost all children are seeing the health visitor in the first year of life, and some children are receiving quite intensive intervention outside of the mandated reviews. So health visiting really represents a huge infrastructure for early years intervention. But the question remains, can we evaluate this in terms of using administrative data? We explored this We took a target trial emulation approach, causal inference approach, to evaluate the impact of different intensities of health visiting in the first year of life on child outcomes. But as with the family nurse partnership study, we found that we had insufficient data in the administrative data on why some families receive more visits than others. Our problem is that although we have very rich data, although sometimes incomplete, we can use this to describe how health visiting is delivered, but we don't always capture those family characteristics or, in fact, outcomes sufficiently well. And we know this in part through qualitative work. This is a mixed methods study led by Jenny Woodman, who's chairing today, and others. And it's really highlighted the complex reasons why some families receive more health visiting than others, which might include commissioning, availability of other specialist agencies for providing appropriate support locally, and local contexts, including poverty. And these are things that aren't routinely captured in administrative data. The qualitative work has also highlighted the huge impact that health visitors can have on children and families. So despite the challenges that health visiting teams are facing, they do have a real impact on outcomes that can't be captured in administrative data. Softer outcomes that are important to families accrue across the wider system, including health, education, housing. I'm going to leave this here for a minute because I think it's a nice reminder that beneath the data that we're rightly very excited about using, there are real individuals with real stories that can't be captured routinely or quantitatively. And it's also a nice reminder of the real impact that early interventions can have on families. Okay, to bring this all together then, investment in targeted interventions and universal services in the early years is really key to supporting health and development of children and the well-being of their families in the critical period before school. And there's clear evidence that this type of investment will be cost effective in enabling future adults to live long and productive lives. Hopefully I've tried to tell this story about how we can use joined up thinking through linked data and the power that we have through data linkage to consider wider determinants of health and well-being across the life course. That descriptive work is important for understanding long-term outcomes and how we can use this to inform policies on, for example, developmental follow-up for specific health conditions and informing parents and families about likely long-term outcomes. Understanding the overlapping services that are supporting children and who might be falling through the cracks where the variation exists. Exploring the contribution of the wider family context, starting with the mother, but also including considering the household. And this is really just the start. We could do so much more if we had more granular income data, employment and benefits data, criminal justice data, and so on. And finally, that interventions and policies ideally are underpinned by high quality research and evaluation, but this needs to be done very carefully with robust and mixed methods and recognising the limits of administrative data and where we would benefit from embedding other study types, including experimental designs, cohort studies, surveys, in order to be able to answer the causal questions, and also importantly qualitative methods to understand mechanisms of change. So to end then, I want to sort of end on a note about the importance of team science in all of this work. The success of ECHILD has really been a team effort, and building strong relationships with data providers, funders, academic partners has really been key to making this work. As you've seen, I've been presenting work from a number of researchers within our team. We're constantly learning from each other, building on each other's work, collaborating and sharing knowledge. And I really think that this working in this way is what is going to enable us to achieve what we're trying to achieve, improving services and ultimately transforming child health. So I'm very grateful to be working with these brilliant people and thankful to all of those whose work I've presented today. I hope I've done it justice. And then finally, I'd like to thank all the children, young people, parents and carers who are involved in ECHILD, our collaborators at LSHTM and IFS, the data providers, DFE and NHS England, and our funders, ADR UK and NIHR. If you'd like to find out more about ECHILD, have a look at the website. There's loads of great information on there, including on how to access the data. Thank you.
Thank you, Katie, for an a very, very impressive overview of what we've learned from linked administrative data across all kinds of health conditions, age ranges, and family circumstances. It really is a step change, I think, in the way that we can study child and family health. Right, we've got we've got about 10 or 12 minutes for some questions for Katie. I do have some questions on the Slido. I would encourage more of you to add questions. The questions that are there are quite specific data type questions. So I think before we start with, I will get to those. Before those, I'm going to take chair's privilege and ask Katie the question. Which is the study, do you think, Katie, that using ECHILD, your linked administrative database, that you are most proud of?
One of the earliest ones that we did that I had been aiming to do for a long time was the one that I presented right at the start, which is looking at each week of gestation of a baby and how that influenced educational outcomes. And the reason why that was so important for me and why I'm really proud of that study is because it was one of the first times that data had been brought together in that way. So there had been other research, obviously, on gestational age and school outcomes from cohort studies, for example, but suddenly we had the whole population and we're able to look at each individual week of gestation and the importance of that, not just broadly, but for specific health conditions, children with respiratory distress syndrome, for example. And I think it's about understanding that there's so much variation within these broad groups that looking at, sort of broad groups of children with particular health conditions doesn't tell the full story. And I've got a bit of an ulterior motive here because, as you know, Jenny, one of my children was born preterm, and at that point when she was born, I was thinking, but she's not just a preterm baby, she's a very specific preterm baby. She was born at this week of gestation, she's got these health conditions or not, and she lives, in a particular context. And that really brought home to me that we needed much more granular data and that these sort of broad studies weren't enough, and we needed the population size to be able to understand that, to inform how different groups of children should be followed up, by which services, what information should be shared through health and education, what information do schools have about the circumstances in which children were born. So that was the really key one for me. And the other reason for that is because we've been applying. I haven't talked about the journey of getting the data linked together here, but we had been applying for the data to be linked up for years. That study took a long time to come to fruition because of how long it took for the data to be linked together and accessed. We started applying for the data 11 years ago now. It was 2014 when we started putting the applications together. And it took us 10 years to get the data to a point where we can share it now with external researchers. So anyone who's interested in accessing the data, you can go through the process. It's funded by ADR UK, so there are no data costs, which is amazing. We've got this really fantastic data resource, which is open to people to do all sorts of research with. So I definitely encourage you to look into that.
Lovely. What I love about working with Katie, many things, is that not only is she a statistical genius and brilliant at linked data, but I think the warmth and sort of personal approach that she takes to understanding statistics is so important, and to understand the stories beneath the numbers. Okay, so I'm going to go to the questions in the Slido, Katie. I'm going to start with a couple of sort of specific data questions, which maybe you could be quite brief on, and then we'll go to a bigger, wider question. So this is one. This is a very important question. Are there plans to link GP data to the records? Because obviously primary care data is so rich in terms of what it can tell us about.
That is a good question, because that is where the big gap is in ECHILD at the moment, is that we don't have primary care data. So when we're looking at things like, for example, mental health conditions in mothers, we're only seeing that really severe end of the spectrum, those mothers who are admitted to hospital, and many mothers wouldn't be. They would be seeking care and support in the community. we'd love to be able to link GP data in, but logistically and technically it's not possible at the moment, and I don't envisage that it's going to happen in the very near future, unfortunately. But it's something that we are definitely keeping on the table and would like to pursue.
Thank you. Yeah, watch this space, I think. Okay. All right, another quick data question and the bigger one. Another good question, another gap and a good question. Mental health services data. What about data quality of that particular data set?
Yeah.
We haven't spoken about data quality too much.
No, that's a good question. The mental health services data is a more recent data set that we linked into ECHILD in the past year, and it doesn't go back as far in time as the hospital episode statistics, the HES data, for example. So we've only had it for a few. We can only access it going back a few years. And in the earlier years, the data quality was less reliable. So I think the answer to the question is we need to do a lot more exploration about how we can use those data effectively. We've done a lot more work looking at the community services data set, as Jenny knows, as part of our joint work. And we've done a lot of work in understanding the data quality and what it can and can't be used for. So I think we need to do something similar with the mental health data to really understand how best to use it. But there are a few research projects that are coming through to ECHILD. Obviously, a lot of interest in mental health, both maternal mental health and child and adolescent mental health. So I think we're going to be learning a lot in the next few years.
So I was smiling at one of the questions. Okay, so a bit of a broader question, Katie. So beyond academia, what sort of things would support this research? So external evaluations, national surveys, commissioned qualitative work.
What sort of things would support this work?
The question is, what sort of things would support this research? I wonder whether, so that could either mean, how could this database support those other pieces of research, like external evaluations and use of national surveys and qualitative work? Let's go with that one. I think let's go with that interpretation.
Vice versa, is that, yeah.
Vice versa, yeah.
Yeah, I think so in terms of qualitative work, for example, the data are really useful at generating hypotheses, which we can then go forward and explore further in qualitative work. So I think there's some sort of direction there. What I think, and I think all of these sort of data sources are complementary, and bringing them together is really where we learn the most. So the really valuable longitudinal cohort studies that we have in the UK, I've got such a lot of detailed, rich data that we can't capture routinely in the administrative data. And on the other hand, the administrative data have got the whole population coverage. So bringing those two together, where we can use the cohort data to understand and drill down into the things that aren't routinely captured, but nesting those within the whole population administrative data, so we can understand the context of the people that are captured in the cohort study in terms of their, the people who were in their schools and in their communities, is going to be really valuable. The cohort studies have got a lot more granular data on income, for example, which is not something we can use in the administrative data, and is another one of the gaps. But if we can leverage both together, then I think we can learn a lot more.
Right, I think we've got one more question, which is back to another data one. So this is about historic adults and how far back. So the question is, are child data linked to data for individuals that are now adults? So I think that's a question about how far back it goes, how long the trajectory is.
Yeah. So yes, in ECHILD we've got children born since 1984. So those individuals at the latest point of the data that we've got are aged 38. So they are in adulthood. In terms of the linkage between the mothers and their their the babies and their adults, the birth records go back to 1997, so we can link babies who were born in 97 to their mothers who might have been born prior to 1984. We still got their information in the cohort, although we wouldn't have any health information on them until 97 when the HES record started. So yeah, it gets really complex when we try and think about the period of time that we've got for the baby and the mother and the different age groups. But the work that I presented by Steffi has started to look at how far we can go back in the, well, for which cohort of mothers we can go back to look at social care history in the mothers. And yeah, it's the younger mothers who are old enough to be captured in that data, who are young enough to be captured in that data, the education data, that we can follow up going forwards. But I think the easiest way to explore whether you can answer a particular question based on those timelines is to have a look at the ECHILD user guide, which is on the website. It's got a lot more detailed information about the overlap over time.
Yeah, maybe Fran, if you could pop the ECHILD website link in the chat, that might be helpful for people. Oh, Katie's done it. Well done. Okay, so I think there's a couple more questions, but we're going to have to leave them because we're drawing to a close. My favourite one though is, are ECHILD hiring? I think Katie's always advertising jobs actually, so do have a look on UCL jobs. And you know, I think it would be an absolute privilege for anyone to work with Katie and the team in this database.
It is a great team. We've not got we've just interviewed for 2 posts, so you might have just missed it, but I know the kids environment health cohort I think will be recruiting in the next few months, so there's definitely opportunities to work with all of this amazing data.
So I'm just going to close with a couple of reflections and a signpost to future events. So I think this is an extremely impressive talk, has really clearly shown how health, education and welfare experiences and outcomes are all interrelated for children and their families. It came across so clearly both in what you said, but also in what you showed. So I think the message we heard for services is to intervene holistically, think about health in schools, think about schools in health, think about health in social care. It's all interrelated, and because of this linked data set that looks over time across family members, we can begin to study that, and as Katie said, identify the groups that might benefit most at which point in their life from extra support. So Katie is speaking again at the UCL Health of the Public Annual Symposium, which is on 29th of April. So I invite all of you to come to that. This year's theme for that symposium is Shaping Health from Early Years to Older Age. So thinking about trajectories and life course again. The events team will share, put it in the chat. Fran's put the link in the chat. And then it just remains for me to say a very big thank you to Katie for sharing her expertise and knowledge with us, and to everyone who's joined us today for this webinar. I think the recording will be shared as well. Thank you.
Thank you, Jenny.